So question number 17 is with regard to the H. pylori eradication. So H. pylori is a bacteria which is implicated in the peptic ulcer disease. So we are talking about the eradication of H. pylori. So the statement is first is proton pump inhibitor is taken with 2 antibiotics. This is correct. So in the eradication treatment regimen, we use PPI with any 2 antibiotics out of these three. What are 3 antibiotics? First is amoxicillin. Second is your clarithromycin, and third is your metronidazole. So out of these 3, any 2 can be used. So as amoxicillin, clarithromycin combination, any combination you can take. So PPI with 2 antibiotics is taken for the eradication of the H. pylori. So first statement is correct. You use the PPI with 2 antibiotics. Treatment is prescribed for at least 7 days. This is again correct. For at least 7 days you have to take this. Treatment of H. pylori infection leads to vitamin B12 deficiency. No, this is wrong. Because if you are going to do the eradication of H. pylori, what you are going to see that the vitamin B12 levels has improved. Levels have improved in the patient. So third is wrong. Now the fourth option is patients requiring long-term NSAID should undergo H. pylori eradication therapy to reduce ulcer. Yes, this is correct. Why? Because see, when you are going to use the NSAIDs, the patient is going to develop the peptic ulcer disease if you're going to use the long-term NSAIDs, and H. pylori is also causing peptic ulcer disease. So you do not want the increase to increase many folds. So that's why you are going to first eradicate the H. pylori and then you are going to use the long-term NSAIDs. So this is correct. So answer is 1, 2 and 4. So 1, 2 and 4 is the correct option. So 1, 2 and 4. B option is the correct answer. Now coming to question number 18. Which of the following are the precipitating factors for the hepatic encephalopathy? So you have seen in your emergencies that many patients of the CLD, chronic liver disease, are presenting with a hepatic encephalopathy, in which you have seen that the ammonia level has raised, and because of the increase in the ammonia level, the patient goes into hepatic encephalopathy. So they are asking that what are the other precipitating factors for the hepatic encephalopathy, so that the patient is going into hepatic encephalopathy. So first is hypokalemia. This is correct. When the potassium levels go down, the patient is prone to develop hepatic encephalopathy. Again, septicemia, when they develop an infection in the blood, when infection spread to the blood, these patients are more prone to develop hepatic encephalopathy. Then increased dietary protein load. Yes, because of increased dietary protein load, the hepatic encephalopathy chances can improve. So answer are D, 1, 2 and 3. All of them are correct. So answer is 1, 2 and 3. If we see other risk factors, so drugs like sedatives, like antidepressants can precipitate your hepatic encephalopathy. And dehydration, if you use the diuretics, you have done some paracentesis, this can precipitate hepatic encephalopathy. Portosystemic shunting can precipitate hepatic encephalopathy because the ammonia is now going to be going more into the systemic circulation. Infections, or talked about the sepsis. Hypokalemia, if the potassium level is low, hepatic encephalopathy can be precipitated. Hyponatremia, if the sodium level is less, you're going to see the hepatic encephalopathy. The constipation, you have seen these patients in your emergencies day in, day out. The patient has developed constipation. Now the patient is presenting with the hepatic encephalopathy, and now you have to use the lactulose syrups and go for the 2 or 3 times the patient is going for the motions, and then the hepatic encephalopathy can improve. Increased protein load, so the protein load will increase, including GI bleeding. So in that cases, the hepatic encephalopathy can be precipitated. So these are the conditions to remember with the drug, especially sedatives and antidepressants. Dehydration, including diuretics and paracentesis. Portosystemic shunting, infections, decreased potassium, decreased sodium, constipation, and increased protein load. So these are the factors which precipitate hepatic encephalopathy. Going to another question. Question number 19. Which of the following statement is correct regarding the upper GI bleeding? So upper GI bleeding, first is esophageal varices is the most common cause. No, this is not the most common cause. Peptic ulcer disease is the most common cause. So if we see the figure, we can see there are the various causes for the upper GI bleed. So what is the most common cause of upper GI bleed? So most common cause of upper GI bleed we can see in this kind of question is peptic ulcer disease, which can be because of the NSAIDs or because of the H. pylori. So this is the number 1 cause. Second, you can see is the gastric erosion, NSAIDs and alcohol 10 to 20%. Then you can see it is the esophagitis, third number. Then you can see it can be your malarious tears, 35% or vascular malformations. Then about them we can give 4 or 5 ring. Then varices come to 2 to 9%. Then aortic, otorenal fistula, and the cancer of the stomach. So varices even do not come in the first 3. it is fifth or sixth cause for the varices. So, but we have a tendency that whenever the patient with the upper GI bleed come, we keep on asking that if the patient is CLD, has developed varices, etc., etc. But so varices is not the most common cause. It is the peptic ulcer disease which is the most common cause of the upper GI bleed. Second is eradication of H. pylori in the patient with a bleeding ulcer decreases the rebleeding rates to less than 5%. So a patient came to you, he was having the bleeding ulcer, he was having the peptic ulcer disease. You went for the endoscopy, you find it was the H. pylori. So when you went for H. pylori, you went for the H. pylori eradication. Again, we have seen in the last question with PPI and two antibiotics from amoxicillin, clarithromycin and metronidazole. You gave them for at least minimum 7 days and it has eradicated. Now the patient may ask you, the doctor, can rebleeding occur again? Yes, the bleeding rate can occur, but the chances are less than 5%. So out of 100, even 5 patients are not presenting again with the rebleeding. So this is the correct option. So B is the correct option. Third, patients with a cardiovascular disease who are on aspirin for secondary prevention should not restart their aspirin. So this is wrong. Even some recommendation says that during even the bleeding you should not stop aspirin. For example, see, antithrombotic drugs, an increasing number of individuals present with upper GI bleed while using antithrombotic medication. So the patient was initially having stroke or the patient was initially having MI, and that's why you started antithrombotic medications to that patient. But now the patient has presented with the upper GI bleed. So what will you do? Will you stop antithrombotic agents or not? Because if you are not going to stop it, the bleeding risk will be there. And if you are going to stop it, now you are again in danger of again developing stroke or MI. So what you have to do? So the recommendations are writing, aspirin can be continued during an upper GI bleed. So even during an upper GI bleed, aspirin can be continued. But what you have to be careful about, P2Y12 receptor antagonist like clopidogrel. So in the era of the dual antiplatelet therapy, we give aspirin with clopidogrel, which is the P2Y12 receptor antagonist. So they are saying that P2Y12 receptor antagonist should be temporarily stopped unless prescribed following coronary artery stenting. But if it has been prescribed after the coronary artery stenting, there was the MI and the coronary artery stenting was done, and after that P2Y12 receptor antagonist clopidogrel was prescribed, then you do not have to stop it. So they are saying that P2Y12 receptor antagonist should be temporarily stopped, as well as warfarin have to be stopped, and direct oral anticoagulant therapy has to be stopped. However, early reintroduction of these medications should occur after hemostasis has been achieved to reduce thrombotic events and the death. So you have to start it as early as possible so that the thrombotic events do not occur, like stroke and MI do not occur again, and the patient will not die. So the recommendation is not there that you have to stop the aspirin for secondary prevention. The thing is not coming about the restarting. Even the recommendation, you do not have to even stop them. So this was the source from the Davidson. So it is saying that you do not even have to stop it. Third is transjugular intrahepatic shunt tips should be considered as a therapy only after 1 week of hospitalization for acute variceal bleeding. No, this is wrong. You can go for the early tips as well. So this is known as early tips, in which we go for the transjugular intrahepatic portosystemic shunting. So answer will be B only. So all other options are wrong. So the option will be only B. So going to all options again, esophageal varices the most common cause. No. Peptic ulcer disease is the one of the most common cause. Patient with CVD, you have to stop, do not have to restart aspirin. No, even you don't have to stop the aspirin. Then the tips, transjugular intrahepatic portosystemic shunt should be considered only after 1 week. No, within 1 week it can be done. So the answer will be eradication of H. pylori in patients with bleeding ulcer decrease the bleeding rates to less than 5%. So this is the source from the Harrison. It is saying that in patients with a peptic ulcer disease who are infected with H. pylori, successful eradication markedly reduced ulcer recurrence and recurrent bleeding. Long-term rebleeding rates fall to less than 5%, often approaching those of the general population. Now, current guidelines recommend early tips within 72 hours or ideally within 24 hours. So do not have to stop for even 7 days, but you can start it within 1 day only. In selected high-risk patient with acute variceal bleeding, waiting 1 week is not recommended. Now coming to the Crigler-Najjar syndrome type 1 is here. So we know there are certain hyperbilirubinemia, which have genetic inheritances. So out of them there is Crigler-Najjar syndrome type 1 is there. So they are asking that is inherited. So you have to remember that either they are asking for the Crigler-Najjar, they are asking for the Rotor, they are asking for the Gilbert, Dubin-Johnson, whatever they are asking, you have to give the answer as autosomal recessive disorder, because all of them are autosomal recessive. So they all of them are autosomal recessive disorders. So you don't have to remember differently for all of them. So answer will be A, autosomal recessive disorder. But where you have to be careful, you have to be careful in the case of the Gilbert, because in Gilbert it is typically autosomal recessive, although autosomal dominant forms are also prescribed. So it has been also seen that there are some cases autosomal dominant, but majority as autosomal recessive. So majority, all of them are autosomal recessive. But where the Gilbert is asked, you have to be particular that they may say that there are certain cases which are seen to be autosomal dominant, and yes, this is correct. Okay, so this is correct. Now seeing one of them one by one. So what is this Crigler-Najjar type 1? So we know that in the metabolism of the bilirubin, there is a turnover of the red blood cell produce bilirubin in the bloodstream. So from where the bilirubin is produced, it is from the turnover of the RBC is destruction. Second, unconjugated bilirubin. Unconjugated bilirubin is water insoluble, is transported to the liver. So unconjugated bilirubin is transported to the liver. So in the liver, bilirubin is conjugated by the main enzyme, which is known as the UG1. The gene name is UGT1A1. So UGT is going to conjugate it, UGT1A1. Then conjugated bilirubin can then be secreted into the bile and then into the intestine for elimination in the feces. So in the case of Crigler-Najjar syndrome, this UGT1A1 is completely absent. So if there is complete absence of UGT1A1, the bilirubin cannot get conjugated, and the indirect unconjugated bilirubin is going to rise. So unconjugated bilirubin is going to increase, and it is autosomal recessive. Because there is complete absence, even if you give enzyme inducers like phenobarbital, there is going to be no response. In the case of Crigler-Najjar type 2, there will be partial deficiency of UGT1A1. Again, is it autosomal recessive? Because only Gilbert some cases are seen to be autosomal dominant, rest all are autosomal recessive. Phenobarbital response, yes, because there was partial deficiency. If we give some enzyme inducers like phenobarbital, the activity can be seen, the response can be seen. Now there is Gilbert syndrome. In Gilbert syndrome, there is a mild reduction of UGT1A1. It is again autosomal recessive, but some cases have been seen to be autosomal dominant. Phenobarbital response, yes, it may improve. Dubin-Johnson syndrome, here the problem is not in an enzyme, conjugating enzyme, but the problem is in a transporter. So it is a transporter known as the MRP2 transporter defect. It is again autosomal dominant. So because it's not an enzyme, that's why phenobarbital response is not relevant. We see it on more detail, so we can divide it into either conjugated one or unconjugated one. Unconjugated one will be the one where the problem will be in the enzyme which is doing the conjugation. So in the Gilbert, the problem in the glucuronide transferase and decreased bilirubin uptake. So typically autosomal recessive, but some cases can be autosomal dominant. Okay, so clinical features is very, very mild. This jaundice is very mild, especially during fasting. Crigler-Najjar type 1, type 2. Type 1, there will be absence glucuronide transferase. In the type 2, there will be decreased glucuronide transferase. So what's the difference between the type 2 Crigler-Najjar and the Gilbert? So in all the three, either it's Gilbert, it's Crigler-Najjar, type 1 and type 2, the problem is in the glucuronide transferase. But in the type 1, there will be absent glucuronide transferase. Type 2, there will be very decreased glucuronide transferase. Gilbert, there is decreased glucuronide transferase, but not that much. So it's not going to present like jaundice. It's going to be very mild jaundice. But in Crigler-Najjar type 1, in which there is absent glucuronide transferase, you have given the enzyme inducers like phenobarbital, but the patient has not improved, so the patient is going to die. So there's a rapid death in the case of a neonate because of the cardiac arrest. Well, in type 2, you are going to give the phenobarbital, phototherapy or liver transplant, and the patient will respond. It is present in the neonates. Now there are problem in conjugated hyperbilirubinemia, in which the conjugated bilirubin is going to increase. In this, the enzyme deficiency for conjugation is not there. So the patient will be having the conjugated hyperbilirubinemia, but because of some defect, it is not going to be excreted. So there are two types, Dubin-Johnson and Rotor syndrome. Dubin-Johnson, we all remember that in this the liver is black in color. So the liver is black in color. So in this, inheritance is again autosomal recessive. The abnormality is decreased canalicular excretion of organic anions, including bilirubin. So in the canal, it cannot be excreted. So there will be pigmentation of liver biopsy tissue, so its liver is black in color. Clinical features mild jaundice, treatment is not necessary. Again, Rotor syndrome, it is again autosomal recessive. In this, the bilirubin uptake is decreased and intrahepatic binding will be decreased. So there will be mild jaundice, and again the treatment is not necessary. So this is what can be asked in the exam. Now coming to question number 21. Whipple's disease. Whipple's disease is characterized by, so Whipple's disease is characterized by infiltration of a small intestinal mucosa by the foamy macrophages. So whenever they ask for the foamy macrophages in the small intestinal mucosa, you go for the Whipple's disease. But they are not asking this thing. They're asking that which one of the following histological stain is characteristically used to stain them. So answer is periodic adhesive. So answer is periodic adhesive. So they have again taken this question from the Davidson. It is writing that the rare condition, Whipple's is the rare conditions characterized by infiltration of small intestinal mucosa by the foamy macrophages which stain positive with a periodic adhesive reagent. So answer will be periodic adhesive. Coming to next question, question number 22. Poorly absorbed antibiotics are often used as adjunctive therapy. So those antibiotics which are poorly absorbed, so they are not going to be in the systemic circulation. They are going to have effect locally. So poorly absorbed antibiotics are often used as adjunctive therapies in patients with hepatic encephalopathy. So which are tenofovir or telbivudine. So tenofovir and telbivudine are again going to be, tenofovir is antiviral, telbivudine again antiretroviral. Sofosbuvir or velpatasur, levofloxacin, clarithromycin, neomycin, rifaximin. So we know the neomycin, rifaximin are not absorbed. So they are not absorbed in the systemic circulation. So the answer will be D. So answer will be D. So the management, the principles are to treat or remove precipitating causes and to suppress the production of neurotoxin by the bacteria in the bowel. So what is the principle of treatment, management of hepatic encephalopathy? The one is that you have to remove the precipitating cause, number one, and number two, if that neurotoxin in the bacteria have been produced, we have to suppress the production. So what we are going to do, we are going to give lactulose 15 to 30 ml 3 times a day, is increased gradually until the bowels are moving twice daily. It produces an osmotic laxative effect, number one. Number two, it reduces the pH of the colonic content, so it becomes acidic, thereby limiting colonic ammonia absorption and promote the incorporation of nitrogen into the bacteria. Phosphate enemas may be required in patients where the oral route is compromised or the patient is in refractory constipation. This thing. Number two, they are going to get rifaximin. Rifaximin, what is the dose? 550 milligram twice a day. Is well tolerated, non-absorbed antibiotic that acts by reducing the bacterial content of the bowel, so the bacteria is going to die, and is effective in reducing episodes of the recurrent hepatic encephalopathy. So they've asked the question from here. So rifaximin is non-absorbed antibiotic, and so is the neomycin. There is some evidence to support the amino acid combination by L-ornithine, L-arginine, LOLA. So is the third in lowering ammonia levels and improving encephalopathy. In case of reduced conscious level, endotracheal intubation may be required for every production. So we know that whenever the GCS goes less than 8, we have to go for the intubation in any case. So that's the fourth. Dietary protein restriction is no longer recommended.